present our speakers today. We have Dr. Leah Brubaker. She's our transplant and hepatobiliary surgeon from UCSD. Then we have Dr. Alicia Lichbar. She's our transplant pharmacist. And then we have Donna Saracho. Sorry. She's our life-sharing volunteer, and she's an organ recipient. So if you have any questions, I think they're open to having them during the talk or afterwards if you guys have any questions, and we'll get started.
Okay, I think that's on. You guys can hear okay? I'm also can be really loud, so if the microphone doesn't work, I'll project. So I'm Leah Brubaker. I am one of our transplant surgeons. And for today, we really want this to be dynamic, so if you guys have questions about specific things that you thought about, during your time so far as pharmacy students and such, please interrupt. We really want you guys to get the most out of this. Anyways, I'm Leah Brubaker, so I'm originally from Chicago, and I did my training for my surgical residency, as well as my fellowship in abdominal transplant up at Stanford in Northern California. I just joined the faculty here in September of this year, so hence why I was late, because I can't figure out where everything is here still. It takes me a moment. I became interested in transplant in my last year of medical school. I was actually doing an away rotation at UCLA, and it was my first exposure to transplantation. Where I trained for medical school, there was a transplant program, but it was not necessarily as robust as some other centers, and it also wasn't particularly a trainee-friendly rotation, which is sometimes one of the things I think scares people from transplant, is this idea of maybe what transplant was when it started, which was it is a very rigorous field, but maybe the team dynamics that are now so well established in transplant weren't necessarily as robust. What made me fall in love with transplant is one, I really think that unlike many fields of surgery, there is a finite problem and the patient is critically ill, and we can really offer an opportunity that is both life-saving and life-changing for them and their family. And I think seeing that profound impact on our patients and family really hit home with me. And then my decision to pursue transplant was furthered by the truly very rich team environment. Medicine in general, right, is a team sport, but nothing else is really like transplant, where on a day-to-day basis, I am interacting with our nurse practitioners and nurse coordinators. I am interacting with our pharmacists. Alicia and I talk all of the time. And we really rely so heavily, for example, on our pharmacist knowledge base. Additionally, our interaction with our medical colleagues is really like no other surgical service that I experience. So we talk and really work closely with our hepatologists, our nephrologists, our cardiologists, and it really makes you feel like you're giving just the best care to the patient, because you have all these experts in the field working together in their fields of discipline to come together and do what is best for the patient. And so those are the things that really got me interested in transplant. And then lastly, surgically, it's one of the most complex fields that you can do. It's one of the last big areas where there's big open vascular surgery to reconnect the vessels. So in general, in liver or kidney transplant, starting with liver, you actually remove the native liver and then have to reconnect all the blood vessels that go to and from the liver, as well as the bile duct. And so it's a surgically complex operation. And then likewise in kidney transplant, we have to reconnect those blood vessels to give new blood supply to the kidney. So those were kind of the reasons that got me interested in transplant. Are there specific questions that any of you guys maybe have about the surgical aspects of transplant or the surgical training that gets you there or anything like that I could touch on a little more before talking about some other things?
Dr. Brubaker,
Yeah.
maybe could you tell them a little bit about, do you do any recovering of the organs?
Yeah. So as a transplant surgeon, learning to do the donor operation and recovery of the organs is a big component of your training and of your position. In general, for abdominal transplant, the team that is going to be taking the liver for a particular recipient is a team that will go out and recover the organs. There are two main kinds of deceased donors. The two main types are donors after brain death. So those donors have met the medical legal criteria for brain death. They no longer have brainstem reflexes, and there's a couple tests to confirm that there is that they have met the medical and legal criteria for brain death. And the other category is donors after circulatory death. So in these cases, these donors have not met the criteria for brain death, but the physicians taking care of them and the family together have made the decision that this person is probably not going to return to a meaningful quality of life as defined by either that patient or their family, and they would like to withdraw life support and then proceed with donation. And in those cases, we have to withdraw life support, so the breathing tube and then any medications that are being used to support their blood pressure, and then wait for the heart and lungs to stop before we can go ahead and start with the recovery of the organs for donation. So two kind of different procurement methods in those cases. In both cases, again, the team that's going to recover the liver is the team that usually is the one responsible for leading the procurement, and they often remove the kidneys as well. During the procurement, you also have to make an assessment of the quality of the organ. So you need to make sure that the liver is suitable for transplantation. And what is suitable can be really different for different patients. So if you have a really, really sick patient in the ICU, so for liver disease, for example, there's the MELD score, which is a model of end-stage liver disease. And it's a score from 6 to 40 that's based on a couple different lab parameters, and it really stratifies how sick you are from your liver disease. And that's how people get ranked on the organ waiting list for liver transplant. And the higher the score, the sicker you are. And so somebody who's really, really sick with a MELD of 40, they are going to need a really good quality liver. So the liver, for example, can't have a lot of fatty infiltration because if there's a high fat content in the liver, it makes it a little longer for the liver to start working right away. And sometimes once you reperfuse that liver and get blood flow into it in the new recipient, if it's a little slow to start working, it can lead to worsening coagulopathy in the recipient. And if they're really sick, their body can't quite handle that stress. Whereas somebody who's maybe not as sick on the list, maybe a patient that is listed because they have a tumor inside their liver, but otherwise their synthetic function of their liver is okay, those are patients that can maybe handle a liver that has a little bit of fatty infiltration. Going back to the two types of donors as well, traditionally, donors after circulatory death can be a little slower to get started and can have a little higher rate of certain complications like primary non-function, meaning the liver doesn't work right away, or biliary complications. And again, those livers might be best served in somebody who has a little more systemic reserve to kind of consider for transplant. Any questions specifically about the donor operation? Yeah, go for it.
Not specifically about the donor operation, but about the recipient. I'm curious if, like for liver transplant, if patients are ever like in the midst of something like really bad ascites or like hepatic encephalopathy, and if patients have those conditions going into the surgery, does that make it delayed, or are they not a candidate, or does the transplant treat that right away?
Mm-hmm.
Like what is like the complications of cirrhosis and hepatic failure?
Yeah.
How does that impact their eligibility for being a recipient?
Yeah, that's a really, really great question. So a lot of our patients who have pretty bad cirrhosis do develop portal hypertension, and some of the sequela of that is lower extremity edema, ascites, and hepatic encephalopathy. In general, somebody can have refractory ascites, so ascites that requires frequent large volume paracenteses, and they can still be a candidate. We do try to optimize that pre-transplant by, have you guys heard of something called a TIPS? Transhepatic, yes, maybe, yes. Okay, it's basically a shunt that is created inside the liver I should have shown a picture of this one, but where you basically are directing the blood flow from the portal system into your systemic system. There's a shunt between the portal vein and the cava, essentially. So that way the portal hypertension isn't so bad, and that can help reduce ascites. But what it does on the flip side is it can worsen your hepatic encephalopathy. And so those can kind of be at, kind of on a seesaw a little bit in how we best manage those for those patients. Hepatic encephalopathy is also present in many of our patients, so again, not a contraindication to transplant. It's most commonly managed in patients with medications like lactulose and rifaximin. But again, if somebody comes in and they're getting very sick from their liver disease, and now they've gone from hepatic encephalopathy with some confusion and maybe some asterixis, and now they're progressing towards where they're actually obtunded, and you cannot really get a good exam on them. They maybe are also developing some areflexia in their extremities. Those are cases where that has maybe gone too far. We need to do our best to try to optimize them, but they could be getting in the window that's too sick for transplant. So things that make people too sick are, one, we don't have a good neuro exam. We're not able to, with no sedation, anything, really wake them up and get a good neuro response. We will always do a complete neuro exam and then also imaging of their head to make sure there isn't a bleed, because with these patients, their platelets tend to be very, very low. Their spleen is big, it consumes the platelets. And so those patients are at high risk for a bleed, and that's something that can lead to them becoming obtunded while you're trying to get them transplanted. And an acute bleed in the brain would be a contraindication, because that can typically get worse right around the time of transplant. If the bleed is stable and their neuro exam improves, after usually about a week or so, we'll be willing to kind of reconsider them for transplant, but it puts them in a very high risk category. Other things that make really sick patients contraindicated for transplant is active sepsis. So if we know there is an active bloodstream infection, or say they had a really bad urinary tract infection that's led to urosepsis, those need to be treated and be resolving. And lastly, sometimes people just get too sick from their liver failure. And this is usually demonstrated by worsening, kind of total body edema. So ascites, pulmonary edema, often they need to be intubated. Their blood pressure gets difficult to manage, and they're requiring multiple medications for vasopressor support. And by then, usually their kidneys have shut down. And in those cases, it's a really tough call. Sometimes you can get those patients through, and sometimes they're just too sick. And that's where the team aspect of this, again, gets really helpful. We usually have a meeting with, kind of our anesthesiologist, our cardiologist, our hepatologist, to really talk about, is this patient too sick to transplant? Is there anything we can do to better optimize them? Or did we just we call it miss their window, where we just didn't have an organ available in time? So, yeah. Any other questions about maybe indications for transplant, or again, operation, and I can talk a little bit about what some of their post-operative course looks like as well.
I have a question. If a patient is COVID positive, are they automatically disqualified for transplant?
Yeah, in the pandemic, that's been a real big moving target for us. So let's talk about COVID in two senses. So first is in the donors. So initially, obviously a lot of testing wasn't available for COVID when COVID first came out, and out's the right word, but anyways, so when COVID first happened, we didn't have a lot of testing available. So we were going on symptomatology, and we were very hesitant to use anybody that was a donor that maybe had some COVID symptoms, because we didn't really know about the transmissibility of COVID in solid organ transplant. And obviously our patients are immunosuppressed, and the early data, particularly for kidney transplant and lung transplant, was that those patients did very, very poorly if they contracted COVID, because of the multiple medical comorbidities in the setting of immunosuppression. Further now into the pandemic, having had more time, donors that have had COVID and it's either been resolved, or maybe they presented to the hospital and actually did passive COVID, but it was a long course. And when you look at their PCR values, are actually the cycle threshold, so the number of times they had to go through the PCR machine to detect the COVID virus is higher. Those donors are safe to use as possible organ transplant, for solid organ transplant, with the exception of lung. Lung's a little different for obvious reasons. There's been no transmissions of COVID from donor to recipient to date in the vast majority of patients. And we've gotten more aggressive here, using even a little bit more active infections of COVID, and have seen no transmissions in our liver and kidney patients. And then on the flip side, for the recipients, active COVID is a contraindication to transplant, but it doesn't exclude them indefinitely. So we've also gotten more lenient on this. Initially for COVID, if a recipient became COVID positive, we would make them wait 28 days until we would consider them for retransplantation. And now it depends a little bit on how sick they are, because for most patients, if they have a positive antigen test, and then 5 days later are really fairly asymptomatic, the benefit, but they're very sick, for example, from their liver disease, the benefit of moving forward with transplant is probably greater than waiting for another organ offer. And we've been pretty successful in those cases where we've decided to sort of push the envelope. It's still an ongoing discussion on when is it safe and when is it not safe. If somebody has very active COVID symptoms, for example, they develop true COVID pneumonia on a ventilator, those patients would be put on what we call internal hold or status 7, which means you're listed, but you're not going to take any active offers until those symptoms have resolved.
Thank you.
So, yeah. I'll talk a little bit, just briefly sort of about the surgery for liver and for kidney. So for liver transplant, the actual surgical portion of the operation takes about 6 to 8 hours. For kidney transplant, it's about 2 to 3. For liver transplant, you're disconnecting all the blood flow, so disconnecting the hepatic veins from the IVC, the inflow, which is the portal vein, and the hepatic artery, and then the bile duct, and then all the surrounding tissue to remove that liver, and then you redo all of those connections. And the procedure itself can take like a little longer for family members that are waiting because of the time it takes our anesthesiologist to put them to sleep, place the appropriate lines to monitor their hemodynamics, etc. After the operation for liver transplant, people go typically to the intensive care unit. I would say about 50% have their breathing tube removed right after the operation and 50% within the first 24 hours. And then there's some of those patients that fall outside of that window that are very, very, very sick. They may require the breathing tube longer. For most of our patients, they're in the hospital somewhere between 5 to 10 days after transplant. But again, if they're really sick coming in, then they may be in the hospital weeks to months. And that's not atypical for our very sick patients coming into the hospital. For kidney transplant, again, operation about 2 to 3 hours. They're extubated in general right at the end of the case, and most of them spend about 3 days in the hospital. And that's the only times they're really here longer is they have some significant blood pressure issues or they need more immunosuppressive medications based on how sensitized they are to the general population. So yeah, that's most of the surgical stuff. I don't want to take too much time. I want to make sure everybody gets some time.
What's your favorite operation out of the organs? And then which type of organ do you like to care for most, like post-op surgically?
Oh, that's really hard. I think most surgeons who go into transplant initially are drawn to transplant by liver transplant because it's the technically more complex operation of the two. I think that's what draws most people in. But then you do your first kidney transplant and it's pretty awesome because you put the kidney in and not all of the time, but a lot of the time it pinks up right away and it will start making urine, and that's like also a really satisfying feeling because those patients come in on dialysis and many times get to leave off dialysis, and so there's this very immediate feedback loop, which is very gratifying, obviously, as a surgeon. So it's really hard to pick, and I'm really happy that I get to do both. I can tell you that other abdominal transplant surgeons also sometimes do pancreas and intestinal transplant, and I did some of those in my training, and I would definitely prefer liver and kidney. Intestinal and pancreas are technically complex, and they still don't, their graft outcomes are still very tenuous after the surgery. That's really hard to manage those patients. So liver and kidney are just a little more gratifying. And then what was your second question?
What do you like to pick? Like
Post-taking care.
Yeah.
And again, I really like the mix, and that's one of the reasons this field suits me so well. The kidney transplants, for the most part, are pretty routine. You have like kind of 2 pathways for kidney transplant: the kidney that works right away, and the one that has what we call delayed graft function, which means they require dialysis within 1 week of transplant. The management is, it's pretty straightforward. You manage their blood pressure, manage your urine output, and so it's nice to have some routine. And then the liver transplants also sort of have 2 pathways. The people that get extubated quickly, their numbers come down quite quickly, and they're sort of on that 5 to 10 day pathway, and the ones that are really complex and really, really sick. I would say the sick liver transplant patients definitely, as a physician, take it out of you more. That you're really stretched in your capacity as a physician to really optimize their care, and so it's definitely a bigger challenge. So it's nice to have the mix of those 2 patient populations. I'm not good at picking.
You don't have to, because you do both.
Yeah, and I really like having both. I think it's, in transplant you're already doing sort of a limited number of operations, and so it's nice having the 2 different organ systems to really work with and manage. So yeah. Any other questions before I pass the mic? We can always come back. Cool, all right.
Take my mask off,
See my back on for you.
so you can see my face. There are tens of you here. I had so much coffee in clinic, I have to stand up. So there's enough of you that I'm actually gonna get to know you guys, and then we're gonna talk about transplant. So kind of starting in general, what do I have here? P1s? Okay, mostly. P2s? P3s? P4s? No, they're busy. They have work to do. They're graduating soon. So just kind of going around the room, starting from the back and kind of working your way up. Tell me just your name and then what your favorite disease state or course has been so far. So you gotta say it loud and proud though.
My name is Teresa.
Okay.
And we don't really know much about disease states yet, but my favorite course is probably pharmacokinetics.
Okay, cool.
Hi, my name is Rebecca. I'm P1, and then my favorite course so far is biopharmaceutics.
Okay.
Hi, my name is Michelle, and I really like learning about allergies.
Okay, awesome.
Hi, my name is Hua. I'm a P2. And I think my favorite disease state more about research into cancer pathway.
Okay, very cool, very cool.
Hi, my name is Ronoj. I'm a P2, and I would say my favorite disease state I like to learn about is diabetes.
Awesome.
Hello, my name is Ahmad, and my favorite course is cardiology.
Fantastic.
I'm Katie, I'm a P3. In P2 year, I think I liked the nephrology and the renal block best. And then in therapeutics, I've really enjoyed everything cardiovascular.
Cool.
I'm Jeffrey, I'm a P1. I really enjoyed pharmacokinetics as well.
Very math. Very cool. Okay.
I'm Grace. I'm also a P1, and I'm in Dr. Snow's hepatitis elective right now, which I'm enjoying so far. So,
Okay.
yeah, it's been-
That's good to
yeah,
hear. No
yeah.
pressure because she's like
Right there, yeah.
right there.
It's terrible.
You
Yeah.
guys disclose that conflict of interest.
I'm Laura. Probably my favorite block has been PDI. That was really interesting.
Okay.
I'm Thomas. I really like pulmonary.
Okay. Fantastic. What if I told you that there is a specialty in which you could do all of your favorite things? Transplant. So I'll go back in time. So about 10 years ago, I was in pharmacy school. My path was very non-traditional. I worked and was in Pittsburgh at the time. I went to school at the University of Pittsburgh, School of Pharmacy. During my pharmacy school time, I had a job at a drug and alcohol rehab center. So a majority of my time was spent between there and the associated free clinic. And then I also did my internship at a clot clinic and worked in patient psych. So very busy. And if you would have asked me as P1, P2, P3, and like actually P4, I probably would have said I was going to go into psychiatry, you know, as a PGY2 or as a subspecialty. But I kind of liked everything when I was going through school. I didn't dislike any one subject. I thought they were all kind of neat. They were all kind of fit together in some weird way. And when I matched for my residency, I matched at the University of Pittsburgh. And we had pre-interviews where you have to say like what you want to do with your life. And I was super contributory to that conversation because I said, I don't know. It all sounds good. And my director, Heather Johnson, who's amazing, also liver transplant faculty at Pitt, kind of gave me the whole talk of what forays were. And she basically called my clinical interest, they had ADHD. So she was like, you're going to transplant, second rotation, whether you like it or not, I don't care. And for me, I was nothing special on paper GPA-wise. I had a C in immunology, and I told her that I'm sorry in advance. She triggered a lot of Catholic guilt right in that second. But I was on lung transplant, which is where I got sent, and I showed up to rotation, and I felt, and this is gonna sound really corny, but I felt like I was going on a date with somebody that I felt like I was gonna marry. Like, you come home and you're like, this went really well. It's not supposed to go that well. It's supposed to be awkward. And after the first week, I loved it. And since then, I decided to early commit for solid organ transplant at Pitt. If you guys know nothing about Pittsburgh, one, it has potholes. 2, the Steelers are there. They have a really terrible baseball team, the Pirates. And then 4, it's like the birthplace of modern transplantation, right? You have Dr. Starzl, who kind of perfected the technique of liver transplant during his time at the University of Colorado and brought it to the University of Pittsburgh. It was one of the behemoths on the East Coast. It's where actually tacrolimus was developed and perfected by Dr. Venkat Ramanan, who is my PGY1 research mentor. So it was really cool to be there and kind of have that experience. And then I decided I liked transplant a lot and also liked research a lot. And then I found myself at the University of Cincinnati, where I decided to do an additional 2 years of training, which is not something that a lot of people sign themselves up for. So I did fellowship. For me, what fellowship was a chance to get my master's of science in clinical and translational research, because something that I believe in as a pharmacist is working on a lot of different currencies. Like, yeah, it's great I know drugs, yeah, it's great I know disease states, but I like to have other functions on the team too, kind of to be that jack of all trades to kind of fit whatever the team needs. So I got that degree to help with statistics within our department, to help with grant writing. And for the last 4 years, up until I moved here, I was an assistant professor at UIC, or the University of Illinois at Chicago, where I ran our transplant elective. So we had our own. Ours was maybe better, but until I left, and then probably not as good anymore. And we had these opportunities to teach and precept. I spent a lot of my time in the transplant ICU. We're a high volume kidney and liver center. We also did pancreas and intestinal transplant. We were the second largest pancreas center, second to Ohio State. So we kind of saw a little bit of everything. And then I found myself here kind of in the middle of COVID, because Chicago gets cold in the winter. We had a negative 40-degree winter, and then that was where I tapped out of Chicago. So since coming here, kind of what my role is also to be the jack of all trades. I'm no longer faculty, I'm like a volunteer faculty or something like that, because I precept both students and residents. But where you'll find me most is in the inpatient or the outpatient setting. I spend a lot of my time in the transplant clinic, just making it work. You have these patients that come in. Our average patient reading level here, probably around 5th grade. In Chicago, our average reading level is about 3rd grade. And you're having to explain very advanced, complex pharmacotherapy to basically your grandma. And you have to make sure they're gonna do it right and do it perfect pretty much every time. So I really like the patient education component. And then on the inpatient side, I'll round with the team, irregardless of the organ, and come up with treatment plans for the patient that day. It's usually a team-based decision. And then a lot of my work on the inpatient side, outside of managing their disease states, their medications, is coordinating their discharge, playing bad cop with insurance. Again, just finding ways to make it work. And then my last component, or the last hat that I like to wear in my job, is research and QAPI. So QAPI is basically process improvement, and we use that as a facet to help kind of perfect our protocols, try to optimize what we're doing. The decision trees that we make, inpatient, outpatient, are they working for us? Do they need improvement? Things like that. So I kind of help with that facet of the program also, just because if I'm gonna get a master's degree and be in more student debt, I might as well use it. So far, I really like it. I help also nationally. So a couple years, 2 years ago now, I was the chair of one of the PRNs for ACCP. So we kind of promoted things on a national level. So a group of us worked really closely to get the immunobill passed, and then worked also kind of developing different compendias to help with Med B drug approvals on a more national level. Because insurance, while it's necessary, it's also kind of our biggest enemy sometimes. So we have to find ways from a national systemic level to make it a little bit easier for ourselves also. So that was a lot. What questions do you guys have?
I'm gonna interject one thing while you guys think of questions, but for example, having like Alicia on the team is huge. So like when we're having our daily inpatient rounds, our team of pharmacists, the things that they sometimes pick up and comment on and direct our attention to are sometimes things as a surgeons or the nephrologist, hepatologist, we're thinking about maybe a different side of the picture, and they really make sure we don't drop the ball. And I can't explain how important that communication is, both inpatient and outpatient. And then that knowledge base, right? Your knowledge base and the way you've trained is a bit different. So having that difference in perspective and difference in scope adds so much value as a team member. And just from Alicia being at different places and training and then practicing at different locations, you also gain so much information about how things are done elsewhere, and bringing that all together in a team-based practice, I think really continues to elevate our ability to care for patients. And so the number of times that she's brought up things, I was like, oh, that was a really good point. Let's learn about that, has been huge. So that's, I think, one of the coolest things about transplant is how integral every member of the team is. And I think that's really unique about the discipline. Sorry.
Yeah, you definitely don't. I mean, having practiced in residency where first year you kind of tumble around to all the specialties. I mean, transplant is the most team-based. The Centers for Medicare and Medicaid Services pay us to be on the team. We have to be on the team or the center will be shut down. They have to have a pharmacotherapy expert. I save the money. I improve patient safety. I pick up on different things. Obviously I'm not in the operating room like elbows deep or retracting, but for the most part, when that patient comes out, like when I was in Chicago, I knew when they were gonna ask for factor 7 when poop hit the fan. Yeah. I knew when they were gonna ask for, Kcentra, or like I knew that, they're gonna be in the anhepatic phase for a really long time before those kidneys come in. Do you want to redose basiliximab? Sorry, you got a lot of blood loss. And you kind of pick up on these very specific drug-related things that are probably on the back of their minds, but they're not on the front burner. But because drugs are pretty much always on my front burner, it's easy to kind of integrate that in. What I like about our practice here is our team is so reliant on each other in a way that I think just elevates all of us. And I don't think a lot of teams, transplant centers aside, specialties aside, is very unique to our center. Kind of from every organ, I kind of have felt that kind of dynamic team sense too, which is really cool. What questions do you guys have?
As a solid organ transplant pharmacist, do you work with all organs or just do you specialize as well?
So originally, during your training, you have to kind of rotate through all. Accredited programs will generally have some CT component, some abdominal component, and then if you don't have those organs, there's opportunities to either self-learn. So at my center at the University of Pittsburgh, if we found it on the side of the road, we'd probably try to transplant it. So they did all the organs, and they did combinations. For me too, I also went over to our children's hospital to get some more hands-on intestinal pediatric transplant experience, which was really, really valuable for me. When I was in Chicago, we weren't a CT center. We were only abdominal transplant. So I kind of subspecialized below the diaphragm just because when you're there for 4 years and that's what you're focused on for 4 years, you're gonna develop a different level of knowledge that's better. Here, I rotate through all organs as the float transplant pharmacist. But eventually, once we hire some more FTE, I'll get a home destination, hopefully probably below the diaphragm. But I do like heart also. Heart was actually, as indicated by my tattoo, please don't tell my mother. I did a lot of heart transplant when I was in VAD, ventricular assist device, when I was at the University of Pittsburgh, and I really enjoyed that too. Just like Dr. Brubaker, I don't like to decide. I don't like to pick favorites of my children, so I kind of like all of them for very different reasons. I am also in the lung transplant and heart transplant here too. I spent about 50% of my time in each section, I would say. And I think there was a question back there.
What complications do you normally see post-op, and what drugs do you use to treat them?
Diabetes. I would say our biggest complication, most commonly seen, is regardless of the organ, I would say it's just hyperglycemia. We use monster doses of steroids. A lot of our patients, just kind of given the subpopulation, especially in kidney transplant, usually have metabolic things going on. When I was at the University of Illinois at Chicago, we didn't have a BMI limit, so we would transplant up to a BMI of 60 because we could do laparoscopic, and then tried to give that person 500 milligrams of methylpred, and you tell me how their sugars are gonna be. So I would say for us, diabetes and managing their sugars is probably the main focus of a lot of my clinical attention on the outpatient setting. I would say in terms of unexpected complications, infections are probably the most common within the first month. For the most part, it really depends on what organ it is going to be what you contend with. From a kidney perspective, urinary tract infections are the most common, mostly because we have a stent that we kind of use to help, with the flow of the urine from the kidney to the bladder. And that's kind of instrumentation. So your body doesn't like that, and you're immunosuppressed. So UTIs are probably the most common. What my role is as the pharmacist is making sure we have good stewardship when it comes to prescribing those antibiotics, because the last thing you want is to have a lot of good oral options kind of go to waste and have to be forced into using IV therapy, which no one likes to do. Patients don't like it. You have to figure out insurance with that, so good luck. So stewardship is probably the second thing that is paramount with that particular complication. Third, I would just say GI side effects for a lot of different reasons, but mostly the immunosuppression, and then patients will try to eat things that they maybe haven't in a long time when they're not on their dialysis diet, and then you'd have to kind of figure out if it's the medicine or if it's the in and out or if it's the whatever. So I would say we deal with a lot of little mini complications, but infection is usually the highest on our radar in the post-transplant setting.
And one other thing I think you guys help with a lot, both, at least for abdominal transplant, our liver patients often develop AKI afterwards, so acute kidney injury. And so renal adjustment of medications, they often also are at risk for infection, so appropriately dosing those antibiotics, that's really helpful. And then post-transplant, for example, the kidney patients, their GFRs, if they have delayed graft function, may take a while. So again, helping us make sure we're renally dosing those medications, not over-medicating the patient. And then as their renal function improves, sometimes it's easy to forget to readjust their medication. And so that's another big point that I think you guys really help with in the outpatient setting, is making sure we stay on top of that stuff.
Yeah, and you'll see that in a variety of ways in other organs too. So renal dosing might sound really mundane to you guys, but I can't tell you how many major interactions or major adjustments I've caught that just aren't on the radar of others because they don't have that specialty subtype training. Like a great example of that, when I was in lung transplant 2 months ago, I caught a patient that was prescribed allopurinol and they were on azathioprine. That's important because if you put on the two of them together, you're gonna have neutropenic fever just a little bit of time. And if you get neutropenic fever, then you're gonna have sepsis. Then you could be facing, a patient fatality. So for us, patients will call and you have to use that, they asked if they could use allopurinol. No. And then redirect and then try to figure out get in touch with their primary, tell them they have to use steroids instead, or tell them, they have to try something alternative. So I think having that side of my brain help, even though it might seem super mundane in school when you're like, I'm never going to need to know this, you actually use it on a daily basis.
And your physicians will forget all those interactions. They learn them and they know them when they're like a fourth year medical student and intern second year, and then by the time they're an attending, they're like, is there any interaction? They just forget. There's so many other things. Everybody has to know so much. It's why the team is so important, and so it's huge. I know it sounds mundane, but it's huge.
Especially, I would say this might date me, but I was actively training when we had our first oral agent for HCV, and prior to that, it was only interferon. And if you don't know what interferon is, great history lesson, not fun in practice. And for us, there was a point where the HCP guidelines were being updated basically weekly, and we were in charge of having to figure out what we needed to do. In the last couple of years, we started using HCV not positive organs, and those patients are going to be on therapy, and you're going to have to know their drug interactions. And if you screw it up, I mean, those drugs are expensive. So having us as that extra layer and as that final, line of check, double check, the team kind of goes down the line in that Swiss cheese model to make sure there's, no misunderstanding on the patient level, no misunderstanding on, the patient's understanding, or with interactions or issues or unexpected things like that. So in a way, we're very valuable. Even though, again, like we're not retracting in the OR, we have a very different hat on the team.
But everybody on our team is of equal
Yep,
value. I think that's
exactly.
really paramount to understand about
Yep.
transplant. Like, I think everyone always thinks of the surgeon as this flagship, but it's not. Like, we are all together on a boat, equally rowing to get our patient to safety. Like, it really is. That's what I think is so cool and so unique about transplant, is how much I value everybody on my team's knowledge base. And it's so cool that they're all together, and it's a little bit different.
Yeah. We won't start rounds until there's a nephrologist there for our kidney patients. We won't start rounds until there's a hepatologist there for our patients. We will wait for everybody, and no one gets left behind. And I think that that's a really important characteristic of our workflow, but also it's like a metaphor for how we function as a team too. What other questions you guys got? No? Okay. All right, with that, I will hand it over to Donna.
Hi, good afternoon. I almost forgot I was going to speak today, right now. I'm sitting here like this. And I'm sitting here like this. And I'm like, is this on?
Yeah, it is.
So I actually literally, like in this past half hour, forgot I was speaking. And I look up, I go, oh yeah, it's my turn. Okay, so my name is Donna, and it's really nice to be here again after several years off because of COVID and scheduling. But this is actually one of my favorite things to come to and speak at, because I get to tell you my story. And my story is a little bit different than maybe what you would hear from a transplant patient, okay? I had acute liver failure, okay? I'm gonna tell you my life a little bit beforehand and then now. So beforehand, I was a writer. I was a writer for the Union Tribune, and previous to that, I was a writer in Orange County. And everything was fine up until one Friday afternoon when I felt sick. I took my daughter to softball practice. I was feeling cold, and that was a Friday, and by Sunday I was in a coma, and I was here at UCSD. So what had happened was I had a reaction to a medication, and basically, in a nutshell, it just, how do I say, fried my liver. So up until then, what I've been learning, I wasn't sick prior. Okay, what I learned was when I woke up, I had a liver transplant. So that was freaky, of course, right? So that was about 11 years ago, and little by little, I have had everything explained to me from my daughter and what they experienced, my husband and what they were telling me they were doing, my family, and then my doctors, okay? And all of this, I didn't know what was going on. The first 2 years, I was just like, it was like this, because it was just a thing of clinics and medicines. And the only thing I really took was an ibuprofen every once in a while. So that quickly changed. So I'm still, to this day, even right now, maybe that's why I'm so fascinated, is that I'm piecing together what had happened to me and the process post-transplant. Okay, so now what I do is I go to the schools and I talk to high school students and I tell everybody my story. And it's a little bit different because, like I said, I didn't have a pre-existing condition. I wasn't sick. I didn't have HE. I didn't have cirrhosis. I just had a freaky interaction to a medication. And that medication, I'm gonna tell you guys, because you guys are pharmacy students, I don't tell it to anybody else because they get freaked out. So I had a reaction to the Z-Pack. So it's very common, but it happens. And it's very rare. And actually, Dr. Shinoda was the only one who really explained it to me in kindergarten language. Like, that's the language that I can understand. So she explained it to me. Once she did, it went boop. That's what happened. Okay, so my life prior to that had been fairly normal. Working, I don't know what normal was, working 70 hours a week on a computer, typing, making deadlines, doing pay stuff, and doing all that. But post-transplant was a little bit different, because when you don't have life and life is given to you, life becomes a different four-letter word. So all of a sudden, I didn't need that 70-hour job. I didn't need to worry about stress. I tried not to stress myself out over the little things. It became all about a different life. It became just completely switched. And I think the team here at UCSD, who I have such a soft heart for, anytime I see UCSD and transplant, I just went, because really it is a collective team. I've made so many good friends. I mean, I can't wait to see Dr. Kona during clinic sometimes. I want to run and hug her all the time. I mean, she's amazing,
Same, I want to run and hug
I know, and I might even see you at clinic on Thursday. So, I mean, it's just, life is different. I still work because I'm still, I can't stay home. I work part-time now, but I work for Major League Baseball. But it's a whole different gamut. It's a whole different thing. I look up and I thank my donor every day, but I thank them twice for the little things that I get. My daughter was able to graduate, go to college, get a job, and guess what? Guess who got to see it? Me. And guess who I got to share that with? My family. And I get this question a lot, is have I met my donor? Have I asked to see my donor? I have not yet made that connection. I always say I give it a milestone. Okay, I'm gonna wait till 1 year. And then it became 5 years. And then it became 10 years. And it's just because I don't think that I am ready internally to meet or to connect with a family who went through their loss themselves. It's almost like, we call it survivor's guilt. So I do it this way, I tell you my story. And it's been an amazing journey. It's been wonderful. I've met a whole group of transplant friends. We all know what we're going through. If somebody's up at 3 o'clock in the morning, I guarantee you one of my other transplant friends are up at 3 in the morning because of Jack Williams. We all know about the med adjustment. Sometimes we'll meet a new transplant patient who's kind of a little fuzzy about everything, and we kind of guide them through. They're like, why did they increase my TAC level this time? And I go, don't worry about it. Welcome. It's going to be a whole thing of ups and downs. When the people that you really, really get to know are your pharmacist, because you get to see them, and then you get to know your pharmacist at the pharmacy, and then you get to know all your transplant friends. And it's a wonderful journey because these people know your struggle. They know the deal. They know that if you're going to have a bad day, that you take that day off. Because guess what happens? We don't have an immune system. So if we get a cold, it hits you like a Mack truck. And we have to learn to really not push that envelope too far. Because guess what? We're going to the ER and they're going to them. So we learn over the years to recognize those symptoms. Immunocompromise has just become really, really famous, that word, in the past 2 to 3 years. I've been living it for 11 years. I was the one at the ballpark with a mask. Now everybody is. I like to say I started the trend, but
These are the top fashion magazines.
Yeah, exactly. But you can always find a mask in my locker. So, that's what it is. I was thinking about how I was going to tell my story to you today. And the only thing that really stuck in my mind was that when you don't have life and life is given back to you, it becomes a different four-letter word. It's a different four-letter word. I can't tell you how blessed, and you will find the most positive people on this planet that are the ones that received an organ transplant. Because I've had friends that have had an organ transplant and maybe lived about 2 to 3 years and are still blessed to that day to receive that gift. I live it every day. I never have a bad day. Well, I try not to, you know, I mean.
You're allowed to have a bad day once in a while.
I know, but then I think about, like, then we call, you know, we talk about it, we're like, well, it's not so bad, you know, but I mean, it's like, it is, and it really, like I said, I forgot I was speaking here, because, you know, we were talking about, it is a team that helps you. It is a team that really, really, I mean, what you're talking about, I'm like, you guys did all that to save little old me. You know, I'm indebted to you. You know,
Well, this is why we do this.
all of you.
But you're also a member of the team, right?
Exactly, because I'm your end product.
Yep.
You know, and yeah,
Centered around you.
Yeah, well, you're the team captain.
You hold the team
because-
captain. You're the flagship.
but I'm like, you guys did that. I'm like, ah. But anyways, but it is. You brought up diabetes, and I'm going to tell you this. When I left the hospital, I was blown away because remember, I was not used to taking medication. All of a sudden, these words, steroid-induced diabetes, became like the whole structure of my life. It really did. And it annoyed me. I was really upset because the first year, or the first 2 years, I believe, I just gained a lot of weight and was due to all the stuff. Doctors were mad at me. They were like, Donna, you're gaining weight. I'm like, you know, and I go, when I got out, you guys told me to eat more, so I'm eating, and now I'm eating, and now I'm stopping, and now I'm still gaining weight. And so I worked really, really close with the dietitian here at UCSD and also with Sharp, so I was doing both. And I worked really, really closely, and little by little, those medications dropped. It went from 28 to like da-da-da-da, now I'm on 4. It's a consistent 4. And it's been 4 for about maybe 5 or 6 years, but the struggle was real. I mean, it took all of me because I was not gonna let insulin ruin my life. I was not gonna let metformin ruin my life. I wasn't gonna take, you know, I mean, I think what turned it around was we were at a restaurant and I had to stick myself, and I had to shoot myself, and I had to wait. And everybody was getting their food and I'm sitting here going, this isn't, you know, I can't do this. And I went to my doctor's office and I burst out in tears. I just said, what can I do? And she was like, well, let's talk about your diet and regulating. I became vegetarian literally for like a good 3 years. And we slowly started introducing more foods. Now I eat whatever I want. But it was a struggle. And because they did tell me that diabetes is a huge, huge problem. And I'm not gonna ruin what these guys did. You know, I'm not gonna ruin anything. I'm gonna take care of this puppy for as long as I can. You know, and it is common. We do name our livers, okay? We do. My friend named his liver Tom. I named mine Mr. Liver. How creative! And but you know, it's been a blessing. I don't turn a burden into a blessing. You know, I mean, it's been wonderful. So I enjoy telling my story. Any questions? I know this ends pretty soon, but any questions that anybody has? I can't answer the medical aspect, but I can definitely answer the emotional aspect.
What's your favorite part about being a life-sharing volunteer?
What's my favorite part? Okay, I'm going to tell you right now, because I talk to the high schools mainly because I'm trying to get them to educate themselves on organ donations before they go to the DMV to make a decision. That's my job. So I try to tell them that, and I go, when you go to the DMV, your answer is you're probably going to decide whether or not you're going to be an organ donor before you vote. So think about that seriously. And the biggest part is when I come back to that school and somebody comes up to me and they go, Donna, I made a decision and I decided to become an organ donor. Or I checked with, you know, like in my schools, the biggest obstacle is culture and religion. I find that 2 very big hurdles. And when somebody comes back to me and they say, I went to church camp, and that was a big topic of discussion. And to me, when they come back and tell me they've made an educated decision, then I know I reached out to them. So I mean, that makes me feel really, really good, you know, to know that I've at least connected with somebody. Or when somebody tells me that they're an organ donor, you know, because they've heard me, you know, or they had somebody. Because I told them, I guarantee you, some of you will be associated with somebody who's going to need a transplant at one point in your lives. Whether it's not you, it's going to be somebody else. So.
Thank you.
No, thank you.
Yeah.
Wow,
Thank you. No, I mean, it's so wonderful hearing your story.
Yeah.
And
Yes.
these are the reasons that we both, I think, fell in love with this profession is getting to see somebody who, I mean, you had a normal life and it was upended in a second, and then to have that second chance, and we could not do it without the donors, and we couldn't do it without your family and without the whole team, and you being a central part of that team. So it's just huge. And I love that you go out and talk to people about organ donation.
It's pretty cool.
It's really getting back to that same cycle, and it's just amazing.
And people always tell me, well, you're volunteering, you know, and they say, well, you know, do you get paid? I go, yeah, I got paid 11 years ago. You know, I mean, no, I you know, I do it in a heartbeat.
Yeah.
I don't, you know, I wouldn't have to work, I wouldn't.
Yeah. And it's really special. I know for us, like just this Monday in clinic, like we work with our social workers that the recipients, if they want to, they can write letters to the family.
Right.
Sometimes the donors will write back. And every time we get those in clinic, you know, we'll all kind of huddle around the computer, and honestly, like, there's usually not a dry eye in the house about it, because I mean, for us, like, we get a liver. We don't know much about the donors, but you get to see what they were like, what they did, what their interests were, like who they were as a person, and to kind of understand their gift and their sacrifice and their willingness of altruism to kind of give back. I think it hits us every time, because, I mean, without that, we wouldn't be doing this.
There's a moment when we go on the donor, we were talking about doing the donor before, there's a moment in the OR where we do a moment of silence for the donor. And most often, the families have written something about the donor, and it's a really touching to hear their family and talk about how you gave so much every day to us as, you know, as a dad, as a brother, as a friend, and we're so happy that you can give this gift to others, and you're passing. And I mean, it's still, to this day, sometimes like it's really hard for me to sometimes hear that and then have to do that operation, right? Because it's such an emotional thing to hear the family being so generous and so thoughtful during such a difficult time in their lives, and it's another real special moment in transplant.
Yeah. If you guys are interested, I always like to share the National Geographic has a fantastic free 30-minute documentary on one of the Cleveland Clinic's face transplants. And if you want to kind of learn more about kind of the acute struggle for a newer type of allograft that we're doing, that's usually something that I always have our elective kids kind of watch and appreciate, and kind of we have a discussion about it. But I mean, you go through the ringer.
Yeah.
You go through boot camp. Shirley has you doing the tires, you know, and like our patients come out of it, you know, so much better and stronger, and they know so much about themselves going into it.
You do find out a lot about yourself as a person, or not just emotionally or whatever it is, but it is physically. We recognize the signs and we are on top of it. So I mean, we know right away. You know, we have a runny nose. I don't care what happens. You know, we stay home. We kind of just be, you know. I think we're more in tune with our bodies. There you go. That's the